Well, Dr. Sheri, welcome to the Unfiltered Healing Podcast.
Thank you. I'm happy to be here.
We are happy to have you and dig into this really enlightening conversation. So, before we get into today's topic and the discussion of today's podcast, can you give our audience just a little bit of information about Dr. Sheri, what you do, and then kind of what drew you to this specialty and this niche of physical therapy that you specialize in? Because it is so impactful and it's really, really, really not well understood or not well taught in women's and men's health sometimes too.
Yeah,
So can you give us a little bit of information about yourself and then we'll jump into today's discussion?
sure. Yeah, so I'm a physical therapist. I got my doctorate from Chapman University back in 2011, and I've been practicing since then. I practiced for the first few years of my career in outpatient orthopedics. I did a little bit of skilled nursing, but when I was in PT school figuring out what I wanted to specialize in, I really thought orthopedics, sports medicine, maybe neuro, when I
Right.
was taking my coursework. Um, and then toward the end of PT school, we got one, which this is pretty typical in general physical therapy school, you get like 1 hour to 3 hour lecture on pelvic floor dysfunction and what pelvic floor specialists do. And so I listened and I thought, wow, this is really interesting. You can deal with all these things with the bladder and the bowel and pregnancy and things that are specific to women's health. And this very specific part of the body. And I was like, but I went to PT school because I didn't want to be a nurse because I didn't want to deal with bodily fluids or bladders or anything that had to do with that. So I was like, that's cool, but I'm not going to do that. I'm going to do sports medicine. Right. So I don't know when the transition happened, but I started to actually get really interested in, especially the prenatal, postnatal phase. But all, that this pelvic floor specialty that was out there. And within a year of graduating, I decided I wanted to take the first level course. Um, and I wanted to work somewhere where there was a pelvic PT that I could shadow to really decide if that's what I wanted to do. And so I went from skilled nursing to got a job in orthopedics that had a pelvic PT, and I got to talk to her a lot about what she did and shadow her a bit. And I started taking the coursework. And I always tell PTs who are interested in pelvic floor, when you take the first course, you will know whether you were born to do this or not. Because in the first course, you're in a room with 40 other 40 other PTs, right? OTs, some other types of professions, and everyone practices on everyone else. So that
Mm.
first course, when you're learning about the bladder, the vagina, the urethra, and the anus, and the first time you have to get on that lab table and other people are practicing on them, like if you can't handle that, you are not going to be a pelvic PT, at least not a good one.
Gonna
Because all
jump
the
right in.
courses, yes, and we are practicing on one another so that we know how everything feels to the patient.
Sure.
And I've always been kind of a very modest person, but at the same time, I just loved the course so much. And I just knew what I was learning there was going to help so many people and just change their lives. And I was like, sign me up for the next course. Like, when can I take it? So that's kind of how, and I
Mhm.
jumped in head first and started treating pelvic floor at my orthopedic clinic. And then before long decided, the standard orthopedic clinic now for physical therapy, you're with your therapist for maybe 20 or 30 minutes, and then you're going to be passed off to an aide or you're going to go do exercises on a machine somewhere. And even though the clinic I was at was great it was a great orthopedic clinic, I was like, I can't treat pelvic floor patients this way. This is not going
Mhm.
to work.
Mhm.
I
Mhm.
want to spend a whole hour with my patient face to face. I don't want to pass them to somebody else because the things that we treat are so sensitive. And a lot of times there's quite a bit of a story to tell. And
Yeah.
you just can't do that in 20 minutes and then have them work with someone who's not a physical therapist, who doesn't have the eye for what we want to happen in the session. So that's when I decided to start my own practice, She Fit Physical Therapy. down in San Diego, and that's what we do. We spend a whole hour with our patients one on one, and this is like what we specialize in. And all of the therapists that I hire, I'm very picky with who I hire. That we have this specific passion and skill set, and that's the way we treat. So I don't
Yeah.
know if
Now,
that's more information that you wanted.
no, that was great. Do you have any like personal experience of how pelvic floor therapy helped you particularly? Because I have my own personal story of how pelvic floor helped me, not with your practice, but with another one that I worked with when I lived in Northern California. And I can expand on that. But do you personally have any success stories for yourself?
So like I just told you, became a pelvic PT. I guess I didn't specify. Before I became a mother, I'd never
Mhm.
had any kind of injuries. Even before I went to PT school, generally speaking, a lot of people have a story where they were injured in athletics and they worked with a physical therapist, and that's what like motivated them. I
Yeah.
don't have any kind of a cool personal testimony like that, either for PT school or for pelvic floor. I had no kids yet. I hadn't had any issues. And so, no.
Okay.
But since that time, I have had 3 kids.
Yes.
So I've had 3 babies. I just had my last one, 7.5 months ago. So I have a 6-year-old, an almost 3-year-old, and a 7-month-old. And I guess my testimony would be that I have been able to run, lift, exercise fairly intensely, through all of my pregnancies. And I have self rehabbed back afterwards. I've had no issues with incontinence, no issues with pelvic pain. I've had little to no back pain in my life. I have and there's, especially during my second and third pregnancies, I remember moments where I was like, not doing the things that I know I needed to do, right, to keep my
Mhm.
body strong and not hurting. And I would start to feel these little aches and pains that I hear from all my patients. And I would tell myself, like, okay, Sheri, you got to practice what you preach, or you're going
Yes.
to end up on the table in your clinic seeing
Yes.
one of your PTs, for all of the aches and pains that people get when they're pregnant. And so,
Yeah.
I guess my testimony would be, um, knowing what I know has really helped me to have easier, more comfortable, more active pregnancies, easier labors, faster recoveries. Um, so I've been able to avoid maybe a lot of the things that other folks have dealt with.
Yeah, so that's a good segue. Why don't we talk a little bit about the pelvic floor in general and what that encompasses? So, a lot of people probably, when they think of like PT for lower back pain or something like that, they're not necessarily taught or instructed on the role of the pelvic floor. And then we can kind of go into symptoms of when your pelvic floor is not functioning properly. So, can you dig in a little bit
Yeah.
before we get into like pregnancy and all that happens? What is the pelvic floor? What are its functions? And how is that different from like just traditional PT care?
Yeah. So I mentioned in traditional, PT schools graduate generalists who are
Hmm.
typically ready to go into like your typical outpatient ortho, typical hospital setting, typical skilled nursing. And then you really have to specialize if you're going to go into something like pelvic floor therapy, because
Hmm.
it's a lot of extra coursework afterwards. Um, so the pelvic floor is a group of muscles. There's actually, depending on what anatomy textbook you reference,
Hmm.
roughly 12 muscles
Okay.
in the pelvic floor. So it's not like people tend to think of my pelvic floor as one big Kegel muscle, right? And it's not. It's 12 different
Hmm.
muscles, and there's a lot of fascia in there. There's nerves that run through it. It attaches to different muscles in the hip. It is very synergistic with abdominal wall muscles, with hip muscles, and with some lumbar muscles, as well as with your diaphragm. So it doesn't live in a vacuum. But at the same time, it's this mysterious group of muscles that's inside the pelvis that you can't really see or access, because the functions of it are not things that you can see. Like, for example, your bicep moves joints, right? It moves your shoulder and it moves primarily your elbow. So most
Mhm.
people can understand, oh, I contract my bicep and it does this. I relax my bicep and it does this. With the pelvic floor, because it's inside your pelvis, you can't see it, you're not touching it. And the functions of it are more along the lines of, and I can detail these in a second, but stability and bladder and bowel and sexual function. Um, People have a really tough time understanding it or connecting with it. And so it's not taught in great depth just in PT school. Um,
Mhm.
so anatomy wise, and I'll pull up this diagram, we're just talking about screen sharing. And this is why I always like to screen share when I do stuff like this, because I like people to be able to see what I'm
Yes.
talking about, but just a little bit of like the big picture of anatomy. So if you think, so your pelvis is down here, what you've got bony structure with your pelvis, and then you've got bony structure with your rib cage up here. So you've got rib cage and you've got pelvis, and then you've got your spine running up, connecting the two. And your abdominal muscles, we can kind of see they wrap around the front, right? Your spinal muscles go up the back of your spine. And then down here in your pelvis, you have pelvic floor muscles, which create kind of a diaphragm in the pelvis. And then you have your breathing diaphragm, right? That sits up here at the base of the rib cage. And so we have
Mhm.
this nice house of muscle in the abdomen, and those muscles, they work together, right? We talked about, so they work as a system, as a team. And your diaphragm and your pelvic floor very much move together with like everything, with both breathing and with core stability. So breathing, the diaphragm and the pelvic floor move up and down together. The abdominal wall moves out and in synergy with the pelvic floor and the diaphragm in terms of breath and pressure management. So they're huge in intra-abdominal pressure management. And then also in core stability. So your abdominal wall, and especially your deepest abdominal muscle called your transverse abdominis, it's synergistic with the pelvic floor in that they very often will fire together, but they support one another in their functions of stabilizing the pelvic girdle, stabilizing the rib cage, and stabilizing the spine, right? So
Mhm.
more detailed anatomy, right? And as a chiropractor, I know like we have three bones in our pelvis. We have our sacrum and we have our two ilia on either side. And the pelvic floor like connects those bones internally. So it helps to compress the pelvic girdle. Your transverse abdominis also helps to compress that as well as attaching to the rib cage. So it's this it's like our internal corset or internal girdle of the
Mhm.
transverse abdominis. And then that pelvic floor helps with that function as well, and the
Mhm.
diaphragm kind of does that to the rib cage. So the rib cage and the pelvis then are connected through the transverse abdominis, and the pelvic floor is the bottom of that canister, and the diaphragm is the top. So that's kind of the anatomy picture of the system. And then if I'm going to try to share my screen here real quick.
Yeah, for all of you just
Tab.
listening to the audio, you'll have to head on over to the YouTube to see
Oh,
the
okay.
videos.
Yes. And I will keep this short then, since a lot of people might not be able to see
Oh, no,
this.
you're great. I just have to
Um,
mention it for people. Oh, there we go. Look at that.
Yeah, so over here on the right side of the screen, let me see if I can. No, I can't really zoom in this view, but I just thought this was a really nice diagram of those two pelvic bones on the sides, and then this is the sacrum. So this is the top-down view where you see this diaphragm of muscle down here from the top that all of your organs, including your uterus and your bladder and your rectum, sit on top of. And then this down here is more the bottom up view. So here's the tailbone, the coccyx, right, on the sacrum, and then the two bones of the ilia on either side. And then you can see that these muscles of the pelvic floor, there's three layers, and they wrap around the vagina, around the urethra, around the anus. They stretch side to side to both sides of the sit bones, up front to the pubic bone, and all the way back to the sacrum. And they run in all different directions. And then if you look at this other kind of sideways diagram here, you can see the spine running along the back, right? And then this is your transverse abdominis that wraps
Oh,
around the
I don't
side.
think I
So
can see.
here's the
I don't think
sacrum.
I can see which image you're at.
Oh, I switched tabs. Okay, sorry.
That's okay.
Let me go to this other tab. Okay, so here's the spine along the back. And then you can see this now, right? Transverse abdominis wraps, kind of around you. The diaphragm is up on the top, and then the pelvic floor is down on the bottom. So you have this enclosed area of pressure inside the abdominal cavity
Mhm.
that moves when the diaphragm, every time the diaphragm moves down, the pelvic floor moves down, every time the diaphragm moves up. So they move up and down together. And then this abdominal wall moves out and in together. So it's kind of the side view. So there's the pelvic floor from the side, right? So
Mhm.
hopefully that gives you kind of an idea of the anatomy. The functions, I'll come back to so you can see my face here. Stop sharing. There we go. Okay. So functions. So everyone knows about the bladder function, right? It closes the urethra. So it keeps us continent. It also closes the anus. So it keeps us continent both with fecal continence and with bladder continence. It also opens
Mhm.
and closes the vagina. So it's very important for birth, for vaginal delivery, as well as for intercourse, for sexual activity. If you have spasm and restriction in muscles that go right around the vagina, you can imagine how that would cause pain. Right? If those muscles are tight and not wanting to let anything in and out. So, sexual function, bladder, not only does it close the urethra, but it lifts the bladder up and forward. So, it helps to support the organ up where it's supposed to be. And
Sure.
then on top of the bladder sit all of the intestines. It's supporting all of your digestive system as well, kind of up, sitting where it's supposed to be. Um, like we talked about, it's also a very important part of core stability. And we talked about the anatomy of that, how it wraps around the pelvis, supports the abdominals, and as part of the core system in terms of not only controlling intra-abdominal pressure, but also stabilizing the pelvis and the spine. So, bowel, bladder, sexual function, and core stability are the biggies.
Great. And when we talk about the pelvic floor and how it becomes dysfunctional, what are some of the top reasons for that? So, we're going to dig into pregnancy as one of the main reasons for that, but there's surely other reasons that the pelvic floor gets dysfunctional as
Yeah.
well. We're sitting creatures, most Americans and people. And so there's other reasons that this pelvic floor can get dysfunctional, improper breathing. So can you expand on that a little bit as well?
Yeah, there's plenty of humans out there walking around with pelvic floor dysfunction that have never had babies.
Yeah.
Right? So, there's a lot of reasons, and let's see, okay, so you asked for the top reasons, the reasons that we see most commonly, and I think one of the most common ones that we see is like sexual abuse and trauma.
Hmm.
Um, so when you have anytime you have trauma to a part of your body, your nervous system is going to clamp down and have all kinds of abnormal patterns and perceptions and guarding mechanisms around that part of your body.
Yeah.
So clearly, anything to do with abuse or trauma to the pelvis is going to potentially cause pelvic floor dysfunction. Direct injury to the tailbone, like if you have a fall off of a horse or a fall when you're ice skating when you're young and you fall right on your tailbone, that can absolutely contribute to pelvic floor dysfunction. Potty training, not great potty training strategies can create, again,
Ah,
like kind of psychosomatic connections with the pelvic floor where it either doesn't release well or it doesn't contract well, or there's psychological components to having dysfunction there. So potty training can be an issue. Like you mentioned, clearly pregnancy is one thing that can contribute. Motor patterns. So we see a phenomenal amount of young female athletes who have incontinence,
mhm.
and some of the reasons pelvic PTs postulate why that could be the case is the way that we train our abdominals and our cores in young athletes. It's not
Mhm.
tailored to the female body. And there are anatomical differences between the female body and the male body that are mostly in the pelvis, right? For
Yeah.
obvious reasons, for birthing. So, the way that we train our abdominal muscles and our hips and our cores is not necessarily very healthy for the pelvic floor. There's a lot of breath holding strategies out there, a lot of just like pull in on your abs, pull, 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 pull. Really heavy load on the hip flexors. There's different things that will just create usually an overactive pelvic floor or
Yeah.
just poor pressure management strategies that overpower it and cause it to have dysfunction. So I think those are probably the biggest ones that come to mind. But
Mhm.
certainly, you mentioned sitting, and prolonged, constant sitting, especially in a poor position, is going to put pressure on the pelvic floor. Um, yeah,
Yeah, I've
those are the
also
biggies.
heard
Any
yeah, I've also heard
time that
of,
I'm forgetting?
I've also heard of, like chronic infections. So, say like someone has a yeast infection for a long period of time, or like
Yeah.
bladder infections, or like interstitial cystitis. Like those can all cause
Yes.
the pelvic floor to kind of dysfunction as well. Have you seen that in your practice?
Yeah, I forgot that whole category of other inflammatory pelvic conditions, right? So, yes,
Yeah.
absolutely. Interstitial cystitis, other types of bladder pathology, endometriosis is huge,
Mm,
PCOS,
mm,
anything where you have an inflammatory process in the pelvis is going to be prone to making the pelvic floor irritable.
yeah.
So certainly if you have those types of conditions, and then you mentioned chronic, repeated infections, but even it can be just like one really bad UTI or
Yeah.
one really bad yeast infection. And that part of your body becomes irritable, and that causes the muscles to spasm, the nerves to get irritable. And then it's just this cycle of, you have spasm and irritability, and then you have pain, and then you have spasm and irritability because you have pain.
Yeah.
So sometimes that can fluctuate with the cycle, with hormonal cycles, with, dietary things. But absolutely, yes, infections and other, systemic pathologies can certainly impact pelvic floor.
Yeah, and I want to highlight that point you just made about relaxation is key, because I think when a lot of individuals, particularly women, when they even discover by a miracle that they have pelvic floor dysfunction, typically the common reaction for most of the doctors and individuals is just to say, recommend, the Kegel exercises, and, oh, things are just
Mhm.
weak, you need to strengthen it, and you need to do this. And so highlighting the part of most of it is also like a spasming and contraction. Wouldn't you say that a lot of those exercises they're recommending are actually making things worse, not better?
Yeah, there's Kegels and there's Kegels, right?
Mhm.
So so there's been a number of studies now over the years on how people do Kegels. And again, because it's a muscle that's inside, most people don't have any concept of what that contraction is supposed to feel like or look like. It doesn't look like
Yeah,
anything, right? You can't see it. The muscles are inside.
yeah.
So over 40% of people who are instructed on how to do Kegels by a healthcare professional with written and verbal instruction, over 40% still do them incorrectly. And there's a
Mhm.
lot of ways that they can be done incorrectly. You can not be doing a pelvic floor contraction at all. You're contracting your glutes or your inner thighs or your abs. You can be bearing down instead
Mhm.
of
Mhm.
contracting. Um, so there's different ways that people do them incorrectly, but yeah, also just doing too many of them. So if you're predisposed to having a pelvic floor that is already like tight and contracted, and then you're told to tighten and contract more,
Yeah.
that's not going to be helpful. And I think one thing that people misunderstand too is the terms tight and weak are not antithetical, right? So you can have a tight muscle that is also weak. And typically, if it's tight, it's going to be weak, because
Mhm.
sometimes if it's weak, it's sitting there in spasm and high tone because it's trying so hard to do its job that it just decides to just be on all the time because it is hanging on for dear life, right? And also, if you have a muscle that is tight and it can't fully lengthen and shorten, it's not going to be strong outside of that tiny little range that it's constantly in, right?
Sure.
So if we go back to our bicep analogy, if my bicep can only move from here to here, it's not going to be very good at doing I can't lift a gallon of milk if this is only as
Mhm.
far as I can move, right? And sorry again for the people who are listening on audio. If you can imagine my elbow, it's flexed almost all the way and I'm only moving it a few degrees, you know? So a muscle that's tight is not going to do a great job. It's not going to be strong in its function.
Mhm.
So a tight pelvic floor is not going to be great at keeping you continent. So again, like, yes, your point to, you're leaking, you're told to do Kegels, your pelvic floor then gets tighter. And so you either don't notice any improvement or change, or you notice it's getting worse. And
Yeah.
certainly with pain, it can be that way also. On the
Yeah.
flip side, if someone is taught to do a Kegel correctly, where they're actually lengthening, so they learn how to lengthen their pelvic floor and let it go, and then contract it, and then the provider says, okay, that's a good pelvic floor contraction. Now I want you to practice that. But that's why the internal assessment is so important. And one of the things that pelvic floor PTs get a little bit up in arms about is that this field is very rapidly growing, right? So we have a lot of PTs out there that are interested in specializing in the pelvic floor, which is fantastic. But they're going out there and taking these, 1 day online course or like an intro course, and they're not learning they're not actually going to do an internal assessment because they're not qualified. So you can explain it to the patient, and there's different ways that you can externally assess if the patient is doing it correctly. But in my opinion, you don't really know if all of the muscles are lengthening
Mhm.
and shortening unless you do an intravaginal or an intrarectal, where you're actually palpating the muscle from the inside and you can feel that the person is letting go and lengthening and then shortening to the degree that we know is normal
Yeah.
for that
Yeah,
muscle group.
I've had many patients, and I'm sure you have too, but I've had many patients where, they're just like chronic low back patients or chronic hip patients, and then I suspect there's something going on internally that I can't see, and so I recommend them doing pelvic floor therapy. And I've had a lot too that said, "Oh, I did pelvic floor therapy." And so when I asked them, well, did they do like an, internal exam to look at that stuff? And they're like, oh, no, they didn't do that. I'm like, well, they
Yeah.
probably didn't get an accurate, examination of what's really going on. And although it's intimate and it's uncomfortable, you have to like look on the inside because sometimes there's a lot of scar tissue going on in there and things that I can't see from the outside. So that's important too for people that have maybe even gone to pelvic floor therapists before and they think that they've addressed
Hmm.
that, but they're still having issues with your back and your pelvis and your digestion and all of this stuff. You need to make sure you go to a qualified practitioner that does internal examinations properly. And I'm
Yeah.
sure you do that too.
Because they're not. Oh yeah, we do. They don't, we don't all have the same training. We don't all have the same depth of knowledge. So, yeah, if you've been to a pelvic PT and never had an internal assessment, find another pelvic PT.
Yeah.
Get, because not that that person's a bad PT, but they might not have the skill set that you need. Right? It's not about
Yeah.
good or bad. It's about not the right fit for you as a patient. So, keep looking until you find someone who's the right fit. Someone who's going to really kind of dig and try to get to the bottom of it. But yeah, the internal assessment is huge. And I know for you, Rachel, you do tend to refer a lot of people who have had chronic, back, pelvic, different types of pain and had very little relief elsewhere. And so even if the exam's uncomfortable, if it's going to get to the bottom of your 10 years of pain,
Yeah.
right? Or even like get you to that next step because you
Mhm.
clear that one more thing that's holding you back, because it can refer to the back, it can refer to the lower abdomen. It's just like we said, it's part of a system. And so if all of the players on the system are not doing their job or one of them is injured, you're not going to get the whole system working well. And so your back might be trying to make up for something that's going on in the pelvic floor. And until you figure that thing out, your back is going to keep talking to you because it's struggling, right? Same thing with
Yeah.
your hip, same thing with your abs. So, but yeah,
Yeah, I
I don't
generally
know.
just tend to see like the same issue coming up over and over and over, or it's just not healing properly. And that's when I tend to dig a little bit deeper and say, okay, there's probably something going on here that I can't see. Um, I want to segue for a minute into pregnancy and kind of the lack thereof of education as far as pre-pregnancy, during pregnancy, and then the postpartum phase, because I know you're also very passionate about that part, because there's such a lack of education for women, and then they end up, in their 40s, 50s, 60s with all of these low back, disc issues, pelvic pain, all of the things that you've already mentioned. So, since there's like zero education for many women, I'm not surprised there's more people that are interested in pelvic floor therapy, because there's such a huge need for it. Um, and they're just not educated about it. And it's very sad, because it's a huge, it's a huge thing that happens to your body. So, what have you seen as far as how things have transcribed into that specific part of what you do? And then what do you, necessarily recommend, or what do you see, how do things change during pregnancy? And then how are they then needed to basically regroup back into proper health?
That's like such a huge question, like a
I'm
huge,
sorry.
long answer to that question. I could talk about
You
that
could
for like
split it up.
7 days. So the first part of the question was, just so I have this straight in my head, was pertaining to what kind of education is provided to people prenatally and postnatally about their pelvic floor. Was that the first part of the question? Help me understand a little bit better.
Yeah, there's like no education there, really.
Yeah, so or very little, right? And
Mhm.
I've seen a lot of clients who weren't even told to do Kegels when they were pregnant. But typically what you're going to hear is, well, they told me to do Kegels, I did them, but not very consistently. And were they doing them right? Who knows? So there's very little education, which is one of the reasons that we always recommend that people get, which is awesome. I've been getting a lot more phone calls lately from people who are pregnant, early in their pregnancies saying, hey, when should I start? Should I wait till after the baby arrives? Or, I've heard that this can be helpful during pregnancy, and it can absolutely be helpful during pregnancy. Because again, most people have never thought about contracting this muscle or relaxing it before they have a baby. And
Mhm.
so it's really hard to get in touch with it. And just the amount of education that we can provide to you during your pregnancy to help you prepare for the delivery and then to prepare for postpartum, right? Because I think a lot of people, especially first time moms, don't realize how crazy that first few weeks postpartum is. Like you can prepare for it well
Mhm.
and you can prepare for it poorly, but you're never going to be completely prepared for it. Like it's a totally different experience than anything that you've had before. And it's different for everyone. So even if you talk to 15 different friends who have had babies, like your experience could be totally 100% different than any of theirs. So, there's just a lot of things that we can help prepare you for during your pregnancy so that that period can go smoother for you and you have a few less things to think about or worry about when you're trying to adjust to having a new baby and being like the sole care provider for another human, a tiny little human that's totally helpless.
Mhm.
So, um, education wise, when people call and they're like in their first trimester and they say, well, what should I do during pregnancy? How many times should I come in? I usually tell people if you have no symptoms, come see us about once a trimester because we can go through all of that preliminary education, help you find your pelvic floor. Can you contract it? Can you relax it? Where is your deep abdominal muscle? Because the things that you asked about, things that change, right? So, the two muscles that get the most change and the most load and the most stretch are going to be your abdominals and your pelvic floor. And specifically with your abdominals, your deep abdominal, your transverse abdominis, I think takes a little bit more toll than the other abdominals do, just because the nature of where the weight is going when as your baby's growing. But the diaphragm also gets pushed up out of the way and the rib cage gets pushed out of the way. So there's really no part of your body that isn't affected by the pregnancy, but the primary changes and the primary load is going to go down into the pelvis and out into the abdominal wall. So those
Mhm.
are the two muscle groups that we're most concerned about during pregnancy. And if you can't find those muscle groups beforehand, or you already have dysfunction that you don't know
Mhm.
about, then you
Mhm.
better believe after a baby comes through or your third trimester when everything's all out of whack, like you're going to have a lot harder time finding those muscles at that time than you
Yeah.
would have if we caught you in your first trimester. So we prefer to see people early on to just identify, anything thing that might put them at a disadvantage early on, and then to educate them how to tolerate the pregnancy as best as possible, how to stay as active as possible, continue their exercise routine without doing any damage, know when they need to modify or when they need to not modify, right? So a lot of people are terrified to do any kind of exercise. I see a lot of people postpartum that are concerned about diastasis recti who are like, well, I didn't do any core, right? Because I know that doing core was going to maybe give me a diastasis. No, 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 no. We want
Mhm.
you to exercise your core. You need your core
Yeah.
for your whole pregnancy, and you need it to be strong when the baby comes out, and you need it to be well connected when the baby comes out. So it's not working your core that's bad. It's a lot of traditional abdominal exercises are too
Mhm.
aggressive for a late second trimester and a third trimester, and you need to know how to modify, and you need to know for your specific body how to modify and when you need to modify. So, um, I got way off topic here, but
It's okay, I love it.
talking about, 'cause Rachel, I could just talk about stuff forever.
I know.
So, in terms of pregnancy, like if you're having no symptoms, once a trimester, and then as you get closer to delivery, you know, we want to give you a little bit more education in terms of how do I use my pelvic floor for the most optimal labor in terms of your pain management strategies, your breath strategies, your positioning strategies, perineal stretching. Is that a good thing for you? Is it not? Should it be used? How should it be used during labor or before labor? So we teach all of that birth prep kind of stuff leading up. More in that kind of last month or two of pregnancy. We'll teach you some of the birth prep stuff because a lot of people do not know how to relax their pelvic floor. And
Mhm.
so they need the confidence of how to not only relax it, but also relax it while they push.
Mhm.
And for women who are planning, I think who want like a natural, unmedicated or home birth, they're a little bit more aware of, hey, I need to learn maybe do some things to learn how to do this effectively on the front end.
Yeah.
But for people who are maybe planning a hospital birth with an epidural, a lot of people don't realize, well, A, you got to labor potentially for a while. So you
Mhm.
still need your pain management strategies, right? Because you're not going straight into the hospital after the first contraction, typically. You're going to be laboring for a while still before you get that epidural. And then once you get the epidural, for some people, it doesn't work or it doesn't work all the way. And so you still need your pain management strategies. And for some people, you're not going to have very good awareness with pushing because you might not feel anything at all. And now your great strength in your abs that was a benefit to you, well, now you can't really figure out how to use it because you can't feel what's happening in that part of your body. So it helps for you to have the confidence going in like, hey, I know in any position on my back, on my hands and knees, in a squat, in a seated position, on my side, whatever position I end up laboring in, I know how to contract my pelvic floor. I know how to relax it. I know how to let it go and lengthen it while I'm pushing and contracting my abs. So that can really help you with confidence for your labor, but also for preventing perineal tears and for potentially preventing the need for like forceps or tools because you just know how to use your body, right? So you're not fighting against yourself when you're in the pushing phase. um, so I think that's a huge benefit that a lot of people don't realize, especially OBGYNs don't think about in terms of why do pelvic PT if you have no symptoms before you go into labor. It's like preparing for an Olympic tournament, right? Or we often compare pregnancy to a marathon or labor to a marathon. It can be long, not short. And so you train for that, right? And so
Yeah.
pelvic PT is one way that you train your body to have the skills that you need, not only to carry the baby, but to deliver the baby, to push the baby out, and then to recover well afterwards.
Yeah, and I think it's
Birth
kind of
prep.
sad when females are kind of scared of exercise during pregnancy because you'll hear like a lot more athletic women, whether they're doing it right or wrong, I don't know. But, a lot of athletic women, they tend to have like way faster bursts and way easier recoveries and bounce back and all of this stuff. So, I mean, there's probably definitely a line of what you can do through different stages of your pregnancy as far as for safety of your pelvic floor. But also, women shouldn't
Yeah.
necessarily be scared of exercise because it does prepare you for the athletic event of giving birth, like you said.
Yes.
Um,
All the research, Rachel, like all the research, barring a specific condition that your physician has identified where exercise is contraindicated or putting you or your baby at risk, exercise is beneficial for you and your baby during pregnancy. So if your physician has not specific or your midwife has not specifically said you should not exercise for these reasons,
hmm, move.
you know? So talk to your physician about it. But if it's just like so and so telling you you shouldn't exercise or you shouldn't do XYZ, you know, check that with someone who's trained. Or if it's just this Instagram person or, this other person who's saying whatever, like you talk to your providers that you trust. And if you don't have providers that you trust, let's find you some providers that you trust,
Yeah.
right? Whether it's your OB, whether it's your midwife, whether it's your pelvic PT, like have someone that's helping you make these decisions based on evidence and your body and not nothing.
Yeah, just to maybe like put maybe some people's mind at ease, are there any like definitive clinical things as far as through those different phases, as the hormones are relaxing, as the body is rapidly changing? Um, Are there certain limitations for working out that, not to like alarm people, but so they should actually feel more confident and okay, I can still move. I'm just gonna obviously keep in touch with how they're feeling. But are there any like clear guidelines there as far as the limitations that should be met?
Yeah, I mean, there's certainly well outlined red flags, right? And contraindications to exercise, and you can find those on the American College of Obstetricians and Gynecology. It's called ACOG, ACOG. You can find those on their website, and they're pretty basic and minimal, right? So, if you're having bleeding, if you're having heavy bleeding, you shouldn't be exercising,
Mhm.
right? You should be getting that checked out.
Mhm.
So bleeding, loss of consciousness, blacking out, getting really short of breath, like you feel like you can't catch your breath. Those are
Yeah.
all things that need to be looked into, right? Like you shouldn't be continuing pushing through exercise. You shouldn't be pushing through pain. You shouldn't be having contractions that get stronger and closer together, right?
Mhm.
So all of those things are reasons for you to stop exercise or not continue. The
What about
guidelines currently,
Go ahead.
sorry, I was going to say for cardiovascular, and this goes for strength too, but really it's your rate of perceived exertion is what we recommend that you use during exercise as a guide. So pregnant women are pretty safe in a low to medium perceived exertion. Medium or moderate level of exertion means that you can still talk. So if I'm running, but I can still carry on a conversation with the person who's running with me, or I'm on the stair climber, but I can still talk to the person next to me,
Mhm.
that's fine, right? If I have such a high level of exertion that I cannot finish a sentence because I'm breathing so hard and I'm working so hard, now you're getting into ranges of exertion that for a typical person during their pregnancy is maybe not recommended.
Mhm.
Um, but if you're a high level athlete, if you're training for the Olympics or you're a professional athlete, you need to have a team of healthcare providers that's helping you make those decisions, right? Because you're still continuing to train at a very high level and that might be safe for you, but usually you're going to want someone monitoring the baby's heart rate if you're training that hard to make sure that the baby is doing okay while you're at that level of exertion. But you want to be working with people who can help you with that. But moderate level of exertion is considered to be totally safe during pregnancy. And even a high level of exertion, usually for short periods of time, is okay. Um, but yeah, low to moderate is what's recommended
What
and
about
considered
weight?
safe.
What about weight limit? So as far as when I think of like the anatomical structure of the pelvic floor, and then you've got more weight and more pressure and more relaxation of all of the ligaments now with the baby growing.
Mhm.
What about like a certain weight limit as well? Because I also see women
So strength training.
probably still loading a lot of weight, and so in my mind I'm like there's got to be a limit there too as far as how much stress that's then putting on the pelvic floor.
And here's the kicker. We don't know. Okay.
Mm.
So you're going to have, because it's only been in the last, I don't know, 20, 25, 30 years that pregnant women would even consider lifting heavy,
Yeah.
like Olympic lifting,
Yeah.
right? I mean, culturally, you didn't have women in the 50s going into a gym and trying to lift a 250-pound bar,
Mm-hmm.
right? They just weren't
Yeah.
doing it.
No.
So this last, 20 to 30 years of the increasing trend of females lifting really heavy in the gym and that being a popular thing to do on a regular basis for normal people, not high-level athletes. It's a recent phenomenon and there is no research on it. Okay. So someone can tell you, oh, yeah, this is totally safe. You can do anything you want as long as it feels good. They're saying that's their opinion. That's not
Mm-hmm.
based on research. We don't
Mm-hmm.
have any good research clinical trials that state that. Partly because it would be unethical to take a bunch of pregnant women and make a bunch of them lift 200-pound bars and a bunch of them not, and then compare the difference, right? That
Yeah.
would
No.
not be an ethical study. So we don't have a lot of research. We don't have any research saying whether a pregnant woman can lift heavy or not throughout her pregnancy and have no issues afterwards, or even have no issues 30 or 40 years down the road, right? Because you're absolutely
Yeah.
right. You have connective tissue in your floor that is not muscle that can get stretched out. And there's going to then be all these other individualized factors in there, right? So you have a spectrum of connective tissue. You have people on one end who have very stiff, genetically, hereditary, very stiff connective tissue in their DNA. And then you have people on the other end of the spectrum who are naturally lax. They've been double jointed their whole life. They have really stretchy connective tissue to start with. And then you throw laxin in there, and they're even more stretchy.
Yeah.
And now, so it's really that pelvic fascia versus loading the pelvic fascia of somebody who has naturally very stiff tissue and maybe relaxin doesn't have as big an impact on that person. They're going to have different outcomes.
Yeah.
They just are,
Yeah.
we don't get to control our DNA. We just don't. So there are things inherent to your body that you need to be aware of when you're making these decisions also on how heavy you're going to load. So then we have genetic, we have hereditary, we have ingrained structural things, right, that are going to impact how much damage you might do. And then
Mm-hmm.
we also have strategies. So a person who has a strategy, a consistent strategy since they were young of holding their breath and
Mm-hmm.
moving with a tucked under pelvis and where they're more rounded through their lumbar spine and their pelvis and then they're holding their breath while they're lifting that heavy weight,
Mm.
that is a much more vulnerable position for the pelvic floor than an anteriorly tipped neutral pelvis and lumbar spine
Mm.
and a breath strategy where you're engaging your pelvic floor and your abs and you're mitigating your pressure through your breath. That's going to be a lot less pressure downward on the pelvic floor. So you have these two strategies then and a spectrum of everything in between. So you've got not only structural things, but then you've also got strategy things that are going to make a difference in how well your body is going to hold up under the pressure that you're putting on it with whatever load you're putting. And then you have the training, right? So if you are just starting a Olympic lifting program, I don't know, 3 months before you get pregnant,
Mm.
your skills and your strength and your muscle control and ability to hold those good, that good form is going to be much less than someone who has been Olympic lifting for 10 years,
Yeah. Yep.
right?
Mm-hmm.
So there's all these different factors. So I don't think that we can make a blanket statement of people should only lift up to X amount of weight, right? I don't think that that's a blanket statement that we can make for like a normal pregnant population. um, because there's so many factors. And that's where, again, I think you need to be working with your birth provider, whether that's your physician or midwife. You need to be working with your pelvic PT and you need to be working with your trainer or your coach to decide what is appropriate for you in your athleticism at each stage of your pregnancy because it changes, right? Over the 9 to 10 months that you're pregnant, your capacity is going to change. And sometimes it changes slowly and gradually. And sometimes it changes very fast, right? So you
Yeah.
can, like last week, I was able to do X, and this week that feels terrible, right? I don't care what you could do last week. You should not be doing something that feels terrible,
Yeah.
So there's a lot of Yeah, there's a lot of factors and it's
Yeah,
very individual.
that's excellent advice. I mean, with anything, we always want to say use, common sense and use if you're trying to lift heavy during pregnancy and you haven't done that before, that's probably not the wisest thing. But even, even outside of pregnancy, a lot of women, like we mentioned in the beginning, can get pelvic floor dysfunction from improperly lifting weights and stuff like that as well. I mean, it can go outside of a man or a woman doing things improperly and it's
Yeah.
too much force on the pelvic floor. And then they get, all this pelvic floor dysfunction as well. I mean, I see like weightlifting videos of women like urinating while they're lifting, and I'm like, oh, I can't unsee that. That's not good. So,
And that's, you say common sense, right?
yeah,
Common sense
yeah,
is common, but
yeah,
common is not normal, right? So just because everyone says it's normal or everyone says it's okay doesn't mean
yeah.
it's okay, and it doesn't mean it's okay for your specific body. And
Huh.
I think also, because this is not talked about very much, which you mentioned
Mhm.
at the beginning, to think that there's going to be common sense around it is even a fallacy, right? Because if no one has ever told a woman, hey, there's this thing called prolapse where your organs can like fall down inside your vagina, right?
Yeah.
So if you're unaware of that, then of course you're unaware of the symptom, which the primary symptom I see during pregnancy and after is just this feeling of like heaviness and there's something there.
Mm,
Incontinence is also a big symptom, but more, I feel like more people are complaining of it just there's a ball there. It feels heavy. It feels like something's falling out. I feel friction. It feels
mm,
loose. I feel like it's gaping open, pressure, right? They feel pressure. And if you don't know that that's even a thing, then your common sense, especially postpartum, is going to be like, well, I just pushed a baby out. Like, I guess this is normal.
sure.
You're not going to ask your trainer at the gym,
No.
right? I mean, I'm not going to ask my trainer, my male hunky trainer at the gym, like, hey, what is it okay that my vagina feels like it's falling out right now while I'm lifting this bar? Is that normal? So I mean, common sense is something that we don't necessarily have because we've never been educated that the symptoms can happen or what they could possibly be related to. And then certainly we have the aspect of everyone says a little bit of incontinence is normal, right? Oh, it's normal to leak with double unders. It's normal to leak with running. It's normal to leak with burpees or on the trampoline or jumping or all of these different types of things because you had a baby, which is not true. It's not normal. It's very common. Over 55% of people who have had babies leak with something, right? With an
Mhm.
urge or with different types of triggers, but a lot of times it's with a physical stressor like jumping or running or lifting or coughing or sneezing or laughing, right? So it's a very high percentage, but it's
Mhm.
still not normal and we can usually fix it because
Yeah.
fourth degree tears where you have like a full rupture of a muscle clear from the vagina all the way through to the anus. That's a fourth degree tear. Yay. They're pretty rare, right? Like
Mhm.
they're not super common. And I've seen women post fourth degree tear even that have no incontinence. They're fine. They can lift, they can run, they can do all the things. So, it's not necessarily true that you're going to have these issues just because you have a tear or just because you have a baby. More often than not, it's because you have some kind of persistent dysfunction. You've got scar tissue, or you've got a muscle that's not firing correctly, or you've got a muscle imbalance. You've got muscles in the back that are hypertonic and that tense, and you've got muscles in the front that don't remember how to turn on, or you've got abdominals that are like way overexcited and overpowering anything that your pelvic floor could ever put forth, you know?
Mhm.
So it's muscle imbalance, or you've got hips that are really weak and you can't control your pelvis from the outside, right? So a lot of our runners, you know, you might have like a seemingly really strong pelvic floor and you feel like you could do 20 Kegels and you're fine. But then as soon as you start running, you can't hold it, right? So a lot of times you have issues with your hips or even further down in your feet or throughout your lower extremity where your lower extremity is not stabilizing your pelvis well when you're running. Your body has forgotten how to absorb shock, and so your pelvis is going all over the place, wibbling wobbling. And it's I always tell people it's like if you ever try to do yoga on a surfboard, right? You might be great at doing tree pose and standing on one leg. You could do it for 60 seconds and close your eyes if you do it on a yoga mat on the floor. But then if I put you on a surfboard, you can't do it for very long, if at all,
Mhm.
right? At least the first time you try. So you put your pelvic floor on a very unstable pelvis where the legs and the hips are not doing
Mm.
their job, and your pelvic floor can no longer do its function because it's not on a stable surface, right? So we're again looking at that whole your whole body. Your pelvic floor does not live in a vacuum. So we need to make sure that your whole body is helping support the pelvic floor in its function as you get back to doing whatever the sport or activity is that you want to be doing.
Yes. Yes, and breathing is a huge part of that too, right? Because so many people improperly breathe, and
Oh,
the
yeah.
diaphragm is part of the pelvic
Yes.
floor as well, and I find that people just
Yes.
don't really breathe properly too. Do you find that a lot
Yeah.
as well?
And it's interesting. Yeah. Well, and it's, I in my current mindset, I'm starting to move away with breath strategy in particular from like, this is the correct or the proper way to breathe.
Sure.
Like, we have lots of options of how to breathe, right? So, a lot of us have learned strategies in whatever our athletic pursuits are, whether it's yoga or weightlifting or horseback riding or dancing or singing. Like,
Mhm.
we've learned different strategies of how to breathe. Whether we know it
Mhm.
or not, we breathe a certain way most of the time. That's how our brain chooses to breathe. And that is not always optimal. So there are optimal or more efficient ways to breathe for different activities that we do in our life, right?
Yeah,
So if I'm just quietly sitting there doing computer work, I'm going to be using a nice quiet resting pattern for breath, or I should be. If I'm running as hard as I can to try to finish first in a track meet, it's a different breath strategy because there's a
sure.
different strategy that's more effective for that activity, right? Labor, pushing versus your pain management phase, right?
Mhm.
So there's different strategies for breathing. So it's not necessarily because I feel like a lot of people have been bashed like you're breathing wrong. They're like, I don't even know how to breathe. It's like you
Yeah,
know how to breathe. You know a lot of ways to breathe. There are some ways that you don't know how to breathe. So
yeah.
let's see if we can use some new options for how to use your body in breathing that will help you connect better with your muscles, right? Because a lot of times we tweak a couple things with the breath and they're like, oh, now I can feel my pelvic floor relax,
Yeah,
whereas before they couldn't because maybe their diaphragm was like frozen in a certain position or they did not want to let go of their abs, right? I mean, how hyper focused is our culture on abs?
yep. Mhm.
Everyone, all they care about is how their abs look, right? I just
Mhm.
I just want my six pack back. I just want my flat belly back. So we've been trained to hold these abs in all the time because we want to look like our belly's flat. And your poor pelvic floor is like, I don't know what to do now. you know?
Totally.
So a lot of time it's teaching people how to relax their abdominals. And as soon as they relax their abdominals, all of a sudden they can relax their pelvic floor. And before they had no capacity to do that. So a lot of times it's breast strategy, and then also a lot of times it's, like alignment, right? Like posture. How are they
Mhm.
holding? So we talked about anatomy, the rib cage and the pelvis, and I'm stealing this terminology from Julie Wiebe, who's a phenomenal pelvic and orthopedic PT. And she's wonderful. She's brilliant. But she talks about, the bell and the bowl. I think that's where I got it from anyway. It was from her. I listen to a lot of pelvic PTs. So the bell and the bowl, right? And they should be facing one another for the diaphragm, which sits at the bottom of the bell, and the pelvic floor, which sits in the bowl. They should face one another. And that's where they're going to have their best function. They have the best relationship. They can talk to one another. The abdominals, which attach both to the rib cage and to the pelvis, are going to have their best length tension relationship where they function the best when the rib
Mhm.
cage and the pelvis are in good alignment toward one another. And so a lot of times during pregnancy, we take on these adaptive postures where the pelvis is either tipped forward or it's tipped back. The rib cage is usually tipped forward to make room for the baby. If you're someone who does a lot of slumping and slouching, like at your computer or postpartum when you're breastfeeding, if you're sitting with poor posture, your rib cage can become like more facing towards the back, right? So when you alter that relationship, you're going to alter the way that the muscles work together. And
Mhm.
so oftentimes when we help people from a strategy that they've been using during pregnancy back towards a more aligned position, they can
Sure.
access their muscles better. They can find their pelvic floor better, both to relax it and to contract it. And that's how they can get back in touch and get that awareness so that they can start using the breath to tap into the pelvic floor and move better without leaking or feeling like things are falling out or having pain.
Yeah, and maybe you can answer this last kind of question before we finish up here because time just flies. Um, we'll have to have you
I
come
know, I
back
just think
because
the
there's
clock
so
goes up
many
to 8
topics.
now.
There's so many questions I have.
How much we
Uh,
didn't talk about.
um, this might not be a quick answer, but as someone ages, does their pelvic floor also change pretty drastically as well?
Yeah, so all of our soft tissue changes as we age,
Mhm.
right? So we see a lot of people in pelvic PT where they're noticing problems and changes. The postpartum, pregnancy, postpartum period, like kind of that childbearing year, that's the number one place where people will notice a lot of changes in this area.
Yeah.
And unfortunately, they're not referred to pelvic PT because OBs don't tend to refer after
Mhm.
pregnancy. You do
Mhm.
your 6-week checkup. Oh, everything looks fine. Do your Kegels, do
Mm.
whatever feels good. You'll be fine. Right. And they don't see you for a year
Oh,
or
no.
two.
Mm.
So none of these things get picked up. No one gets referred. Then you hit the other end of the lifespan, right? Where you're getting another big change is right before menopause when your hormones are all starting to change. So now you've had 30, 40, 50 years, depending on what age you had your babies, for the pelvic floor to either get stronger and more and better controlled and better awareness because you've rehabbed it, or you have these icky strategies that you were using postpartum that you've now been using for 30 or 40 years and continued to kind of
Mm.
wear away at your pelvic floor and maybe make that prolapse worse, make your dysfunction, progressive, progressive
Mhm.
dysfunction. And then you hit menopause and you have these hormonal changes that cause something called vaginal atrophy, which is where, so estrogen is very helpful for our muscle function. It helps us to have nice, big, bulky, um, soft, great musculature, right? Especially in the
Mhm.
pelvic region. And so estrogen is very important for incontinence because it helps your muscles be nice and bulky to hold the bladder up and keep the urethra closed. Well, all of a sudden we hit menopause and our estrogen and our hormone levels are going all wacky, and so we have atrophy of those muscles and atrophy of the soft tissues. Everything starts to get a little bit dried out. Your muscles get thin. You have no idea how to properly do a Kegel, so you can't strengthen them anyway, you know? And you notice that all of a sudden you're having increasing leakage, increasing prolapse symptoms. Things feel like they're falling out now. You can't run the way you used to because you're leaking. So there's changes that happen very drastically in that later phase of life, and that's the other time frame when people will often go complain to their doctor about these things are coming up. And it's much more common to then get referred to pelvic floor therapy when you're 50 or 60 and you're having incontinence or prolapse symptoms
Mhm.
than when you just had your baby. So, it's
Fair
very, yes, there are changes that are happening probably gradually over that period of time, just
Yeah.
like someone with arthritis, right? So, if you get diagnosed, if you get an ACL reconstruction when you're 18 because you had an injury, your orthopedist is usually going to send you to rehab, first of all, for 16 weeks before you go back to any sports, right? You're going to get therapy for several months.
Mhm.
Pregnant women, postpartum women don't get that. But you have an ACL reconstruction, you go to rehab, your doctor and your PT are both going to tell you, hey, your risk now for arthritis is much higher. You need to take a little bit special care of this knee. You need to make sure you stay really strong, stay in the gym, or you're going to start to have pain, and then someday when you're 40 or 50, it's probably going to start to hurt again. We'll need to do some x-rays and see if your arthritis has, set on a little bit early, because we just know from the research that's very common after that type of surgery. And eventually that person will very likely need a total knee replacement, right? But you know what to do between your surgery and the 20, 30, 40 years later to try to optimize your health and last as long as you can and take as good care of that joint as possible. That does not happen with the pelvic floor after pregnancy. So you have people who have no idea how to take good care of their pelvic floor, no idea how to avoid all of the things that could make their condition worse, sometimes no idea that they even have a condition in the first place, right? And then you've got them doing the same strategies for 30, 40 years until they hit menopause. And now all of a sudden, all of your hormonal imbalance and your, you know, physiological things are changing to put you at a disadvantage. And now all these symptoms come on. And now the physician is going to tell you, okay, let's go do some pelvic floor therapy. They'll have you do some Kegels and we'll see what happens, right? But you're probably going to need a surgery. Because, for example, at this stage, if you have significant stage of pelvic organ prolapse,
Yeah,
you might be past the point where rehab can help you, right? Really, your structurals are shot and you do need the surgery. And
sure.
they're going to send you to the pelvic PT, and the pelvic PT is going to teach you how to access your pelvic floor. They're going to teach you all this stuff. But really, we would have rather taught you 30 years ago to see
Yeah.
if you could potentially avoid the surgery. And again, like we don't know. We don't know if doing pelvic PT postnatally could prevent the surgery 50 years down the road because there's no research,
Hmm.
because no one's doing research, no one's proactively prescribing it and saying, okay, let's have this 100 women do it and this 100 women not, and then see when they hit menopause who has bad prolapse and who needs a surgery. Like, no one's doing that research. So we just don't know. But from the logic and again, like the common sense standpoint, this is how we treat other types of injuries. And so you would think it makes sense if we put the person through proper rehab. We teach them how to take care of that part of their body. We teach them how to keep it strong. We teach them how to not stress it out. And then they have tools that they can use for the next 20, 30, 40 years. Maybe not as many of these people will need surgeries.
Yeah. Yeah. Prevention is always
Maybe,
key.
right?
Yeah, prevention is always
Prevention
key.
is huge.
Yeah, and I hope by this podcast, those who are listening will gain and glean more information about the pelvic floor and just the importance of it. And if you're not finding answers, to look into pelvic floor therapy, to keep searching, keep looking, keep finding, because there is help out there, and you're not crazy. You don't have to struggle and
Yeah.
suffer. And there's like a lot of like,
Can I tell one story?
yeah, yeah, go for it.
Sorry, I just have a cool like generational example of a recent patient who she came in and saw us like immediately postpartum for her issues and found so much benefit. She brought in her mom who is on the other end of the spectrum, right? But who has been having these, actually just started, her strong lady, lives on a farm, super active, like strong lady, right? And just recently surrounding menopause, starting to have some of these symptoms.
Mhm.
She brought her mom into therapy and said, "Hey mom, like let's see," and we still, even only seeing her a few times because she was from out of town, were able to make a huge impact in her back pain,
Mhm.
in her bladder urgency, in her, just in her strength and her confidence and her ability to like do what she needed to do. So it's never too late, right? But a cool idea of like, hey, young ladies who are learning about this now, like it's not too late for your mom, your aunt, your older sister, like, oh, guess I should have done that. Now I'm just, destined to pee my pants my whole life. Like, no, you're not.
And it's
Right?
kind
So
of
it's
like a
it's
joke
never too
too,
late to address.
right? It's kind of like people joke about
And the
it too,
pelvic
like, "Oh, I
PT will
peed my
tell you,
pants," and it's like, "Oh, no."
yeah, it's not funny.
Yeah.
It's not funny. These companies that make the incontinence products and the period, the panties and stuff that absorb, which they're great products, we need them, but our goal as pelvic PTs is that we can help you not need them so that
Yeah,
you don't have to spend all this money
yeah,
for the next 50 years on incontinence products. Like, if
yep,
you add up all the money you're going to spend on incontinence products, pelvic PT costs nothing in relationship to that. So I would take like
and
12
quality
pelvic
of
PT
life.
visits, even if you're paying cash out of pocket, is
Mhm.
going to cost way less than pads for the rest of your life and then a surgery when you're 60.
Yes. Yes,
Just
agreed.
saying.
Well, we will end
In
with
the long run.
we will end with that. Dr. Sheri, can you talk just for a quick second about how people find your office, your social media, and then maybe resources for them to look for PTs if they don't, live here in San Diego area where they can gain and glean
Yeah.
information from that?
Yes. So my practice is in San Diego. It's called SheFit Physical Therapy. We have two locations, Pacific Beach and Mission Valley. Our website is www.shefitpt.com. I also have a Facebook and an Instagram account that I try to post helpful information on, for anyone who's interested in just following those. The Instagram is at SheFitPT. The Facebook is a little bit more complicated, so I'll give you the link, Rachel, but I'm not gonna try to say it because it's harder to find. But the Instagram is great. I do have a pretty awesome resource that's free for people who, again, surrounding a pregnancy and a delivery. It's the top 5 things that we see as pelvic PTs. It's the top 5 things that people don't tell you are going to happen to your body or that you might
Mm.
experience. It's a very in depth online workshop, and you can register for that at www.shefitpt.com/online workshop. So you can also post that link. I'm sure you can provide that to your people somehow, but that's free. You can register for it at that link. Um, and then, and we do in office, but we also do virtual. So anywhere in the state of California, we can see you virtually also.
Mm.
And if we think that you really need that hands-on, that intravaginal assessment, and you can't make it into our office, we can absolutely help you find a pelvic PT local, or at least someone who's somewhat close to you. There's a couple great directories. They're national and international directories. Pelvicguru.com is my favorite. And then there's pelvicrehab.com. And then the APTA also has a directory, but I'm blanking on what that link is. But if you search APTA pelvic health section directory, it will come up. Um, so those are the major directories to look for. That's how you find me. That's how you find other pelvic PTs.
Excellent.
Any other questions you just asked me for? I'm blanking on.
No, that's it. That was excellent. Thank you so much for your time today and taking time out of your very busy schedule. And so we just appreciate you. Thank
Pleasure.
you so much. And I just recommend everyone go follow her, her excellent practice, her information, and let's go support her some more. So without further ado, let's end today's session. Thank you so much, Dr.
Thanks,
Sheri, and
Rachel.
we'll see
Thanks for
you
having
all
me. It was
next
fun.
time.